Yeah, thank you very much for inviting me, Ravi, as well to you. Good morning to everybody. I'm happy to be here, and I would like to give you some thoughts of mine and to share it with you and to discuss it with you on preoperative anemia. Does it have an impact? Should anybody of us care about it? And just briefly, and not to overlap with Dr. Richard's talk, to give you an idea how anemia can be managed. This is my conflict of interest, and I have to say with regard to point 3 that I was mandated from the German Society of Anesthesia and Intensive Care Medicine, together with a good colleague of mine, to write the German multidisciplinary guideline on preoperative anemia treatment and diagnosis. Okay, these are the 2 points I would like to talk about. Let's start with the incidence and impact of preoperative anemia in cardiac surgery, and to my opinion, I'm sure that we should take care about it. So, the WHO definition is almost clear to everybody. You know that hemoglobin below 12 in non-pregnant women and below 13 is defined as anemia. And we see that there is some prevalence in children, but also in the elderly, and this is the population we are usually dealing with. And this is just some data from very current trials or database analysis that are showing that was, Dr. Klein has already shown, we have about 30%, up to 45% of patients who present with anemia prior to cardiac surgery. Well, and this is in isolated CABG surgery, this is in aortic valve surgery, but this is also in a more heterogeneous group of patients. So I think, and this is the next study saying to us, although it is not coming from cardiac surgery, we have to regard anemia as something that adds to the risk profile of our patients. So this is a very large analysis. It is not coming from cardiac surgery. It basically excluded cardiac surgery patients, but it involved more than 200,000 patients, and it gives us a closer understanding of what is going on with preoperative anemia. And this is the first result. We saw almost 5% of mortality in anemic patients compared below 1% of mortality in non-anemic patients. And this is the main result from this study. And I have to explain it to you. There are 9 pre-specified risk groups of patients. The older ones, cardiac, severe chronic pulmonary disease, and so on. These purple bars represent that this is the population below 65 years of age. The orange bar says there is one risk factor, either the age or anemia present in this patient. Mortality increases by 10-fold. And the third bar, the blue one, says both risk factors, age over 65 and anemia is present. And this has already increased mortality by a factor of 3. And if you look at all the pre-specified risk factors, you see the same pattern. If anemia is present in addition to the risk factors that almost all our patients have, it is going to double or something like that, multiplies the risk of mortality. And this is one of the largest studies from the US involving 180,000 isolated primary CABG patients with a high degree of anemic patients according to WHO definition. And this is what it says. In the entire population, if you have a decrease of the hematocrit from normal values by 5%, you have an 8% increase in hospital mortality. You have a 22% increase in renal failure. Patients stay longer in hospital, and they have a 10% higher risk of deep sternal infection. And if we look at those patients who were not transfused, and this will be one of my issues, for the next slide to investigate the relationship between transfusion and anemia. If we look at those patients who were not transfused, the impact of preoperative anemia on renal function persisted. The other outcomes were not affected. Renal failure, renal function seems to be very susceptible to anemia. Okay, basically we know that it is not only mortality that is affected, but what makes patients die, that is the rate of complications. We know this from the McSpy group, that in early data with roughly 30% of patients anemic, and this gives you the idea what kind of complications is affected by anemia. This is the hemoglobin on the x-axis, and that what you see, this is a hemoglobin below 10, and you see that there is a steep increase in renal and cerebral complications compared to gastrointestinal complications that seem to be more or less unaffected, and the steep increase seems to occur when hemoglobin is below 12 prior to surgery. So, we did a study in our patients, a retrospective database analysis in roughly 4,500 patients, adult patients undergoing some sort of kind of procedure. You see we have CABG patients, we have bulk patients, we have combined procedures, and we had a look at the severity of anemia. In group 1 is always no anemia, mild anemia, severe anemia, and we had an incidence of roughly 36%, matching fairly well with that what Dr. Klein told. So, and the problem, if you want to see what is the impact, the independent impact of anemia on outcome of your patients, you have to cope with the problem of transfusion, because, as Dr. Klein told us, the anemic patient is significantly more frequently transfused than the patient who is not anemic. So it makes sense to differentiate between what is the impact of transfusion and what is the impact of anemia. So, and we did a logistic regression analysis, and first of all, we had a look in this retrospective analysis on the severity of anemia and its impact on different outcome measures. That was the C is the severity of anemia, if it is mild or severe, has an impact. Mortality is increased by the severity of anemia. 3-year mortality is increased, and also the length of stay is dependent almost linearly from the severity of anemia. Second, what we did was try to analyze, is there an impact of red blood cell transfusion in anemic and non-anemic patients. And this is a Kaplan-Meier curve. I have to explain to you, the solid lines are those patients who were not transfused. This is the non-anemic, mildly anemic, and this is the severely anemic. And severe anemia means hemoglobin below 10 prior to surgery. And if you compare the solid lines to the interrupted lines, which is the group that received the transfusion, you see that mortality over the long-term view is not improved by transfusion. This is not the case in the non-anemic patients, neither in the mildly anemic, neither in the severely anemic patients. So, also we cannot prove any causality, that's for sure. Transfusion remains to be controversial if it really improves outcome of patients. And then the last point we tried to have a look at is there an interaction of red blood cell transfusion and anemia? And the first result from this slide is we did not see an effect on hospital mortality. So we did not investigate this further. We just observed from our 4 6,500 patients and impact on 3-year mortality. Okay, if we then have a look, what is the impact of transfusion in the non-anemic patients? You see there is a doubling of mortality. If you compare to the third line, what is the impact of mild anemia in patients who are not transfused? You also see that there is a doubling of mortality. In mildly anemic patients, transfusion results in an increase by 3 points in mortality. If you have severely anemic patients who are not transfused, you still have a mortality that is elevated by factor 3. But if the severely anemic patient is also transfused, then we have a mortality that is increased by a factor of 5. So we are still, although we cannot prove causality, that it is only transfusion that worsens the outcome, there's at least some idea that gives us a background or a basis for future research. So the odds of red blood cell transfusion and anemia seems to be comparable, and red blood cell transfusion does not necessarily improve the outcome from other things. So I would like to conclude for this first part of the talk. Preoperative anemia is at least associated with more kidney injury, with more organ failure, more infections, more transfusions. It should be regarded as an additive risk factor. It carries a higher mortality. And the good thing is, and I think Dr. Richards will talk about this, can be treated. And it still has to be shown that the treatment of preoperative anemia, apart from transfusing these patients, is improving the outcome of our patients. And I just would like to give you a few ideas of what happens if you treat preoperative anemia. And this is some recommendation that is coming from orthopedic surgery, just to give you an idea what to do with anemic patients that are given here. First of all, Dr. Klein has told us that there is some impact of nutrition associated anemia, iron deficiency. So first of all, try to rule out iron deficiency, and obviously hepcidin and low density hemoglobin seems to play a greater role as it was acknowledged in this type of guideline. And if you have iron deficiency, you always have to rule out the malignancy. That would be the first step. If you do not detect iron deficiency, then have a look at vitamin B12 or folic acid deficiency. And the major group of patients presenting with anemia prior to surgery is the group of patients who have chronic disease, chronic inflammatory, renal disease, unknown diseases. And this will be mainly the group of patients that might benefit from EPO plus an oral or better IV iron preparation. So, and this is just one small study with regard to the treatment of preoperative anemic patients. Small study from Korea. These patients, mainly valve patients, had the intervention of 500 units of EPO plus a small dose of IV iron, and the primary outcome was just a surrogate of transfusion requirements over 4 days post-operatively. It was just more a proof of concept than an outcome study. And that what they have shown, the EPO plus iron group is in red. They have a reduced transfusion requirement, also in the group of patients that were transfused, and they had a reduction in patients requiring multiple transfusions. That meant more than 4 red blood cells, and they had a reduction in post-operative acute kidney injury. So there might be some idea that treating preoperative anemia is beneficial for our patients. But I think all of us is clear that treating one risk factor is not the solution for all of our problems. And that what I feel is that treating anemia should be an integral part of a program. You may call it blood conservation program, you may call it patient blood management, that addresses at reducing the need for transfusion, and that reduces also the incidence of the comorbidity preoperative anemia. And this is a retrospective analysis from the US, a hospital that was dedicated to patient blood management. Gave 586 patients into a database, and other 586 patients that were matched to this patient group were coming from a greater number of hospitals in New Jersey. And the hospitals in New Jersey, they had no patient blood management program implemented. And this is the measures that were taken during the treatment of the patient. And you see that preoperative optimization, treatment of preoperative anemia is only one part. There are some more parts of this program that makes it become effective, and there's involving surgical hemostasis, endovascular vein harvesting, point of care coagulation monitoring. If you put all these different items together, then it becomes a very sophisticated program. And this seems to have some effect if you see that not only the number of transfused patients could be heavily reduced from 22 to 10%, there was a remarkable reduction in mortality and also a remarkable reduction in serious complications that have contributed to the reduction in mortality. So putting the treatment and the diagnosis of anemia into a treatment protocol, this seems to make the most sense to me, and so I'm coming to conclude to my talk. Anemia occurs in up to 50%. I think the UK and Germany is not that far away. We're roughly around 30% of our patients having preoperative anemia. And we know that preoperative anemia is still associated with a higher risk of adverse outcomes, even mortality. If we compare it to packed blood cell transfusion, the odds seem to be quite comparable. And as I told you with my last slides, anemia management, diagnosis and treatment should be a part of a patient blood and blood conservation program. Thank you very much.